King Culture presents A Plan for Longevity, a health and wellness initiative for men. Why health? Why now? At King Culture, we're equipping men to become selfless leaders, and part of selfless leadership is developing a strategy that ensures not only your well-being, but the well-being of those you're responsible for. Why do you feel there's just such a lack of trust for the medical industry, and how can we change that?
I've changed my primary doctor at least 3 or 4 times. You know, trying to be transparent with someone that's new is kind of should be the route you should take, but not always, you know, the route we always take. And so,
my primary care physician has been my primary care physician since I moved to Atlanta when I was like 3 or something like. Yeah.
I need to get your doctor's contact.
I got you, man. I got you.
I'm Domonic Purviance, and on today's episode, we're talking about prioritizing primary care. Who advocates for your health and wellness? Do you have a primary care physician? Why does it matter? In this episode, I'm sitting down with Dr. Ovid Barrow from Emory Hillandale Hospital to better understand how having a primary care doctor can literally save your life. We're going to get into it next. Stay tuned. The King Culture Podcast starts now. So I want to welcome you to the King Culture Podcast. This is our Plan for Longevity series. I'm here today with Dr. Ovid Barrow, and we're going to be talking about healthcare advocacy today. And so I want to welcome you, Dr. Barrow, and give you a chance to sort of introduce yourself. Tell us a little bit about your background and what you do in your current field.
Well, thank you, sir. It's a pleasure to be here and to share some of my experiences. Being an African American and actually coming from South America, I came to this country as a late teenager to Brooklyn. I think a lot of West Indians do go to Brooklyn, and I went to the military. I did a number of years in the military as a hospital corpsman. And after that, I did several other jobs. I will not give you the details of them, but there were many. And I decided to get into medicine. I went to Downstate Medical School in Brooklyn. And after my residency, I decided to move south. I came to Georgia and I started working in Macon. And then from there, I came to DeKalb Medical Center, which is now partnered with Emory. And I've been here for 12 plus years. I work as a hospital corpsman, not a hospital corpsman, please remove that. I work as a hospitalist, meaning that I'm an internal medicine doctor, board certified, but I see patients only in the hospital setting. We see some of the same challenges that the primary care doctors have, but ours are exclusively in the hospital. And what we want to relate to the people is that medicine is like a sort of a relay. We have to make a proper handoff once that patient is discharged with proper instructions so that the primary care doctor can pick up from that and take it onwards.
And so as a hospitalist, you're primarily responsible for patients once they get to the hospital. And are you involved in diagnosing and prescribing treatment, or what's sort of your involvement with the patients once they enter the hospital?
So once they come to the hospital, they'll most likely come through the emergency room.
Yeah, okay.
Once they have made an assessment of that patient, it's like asking us for a consult, basically, and what the needs of that patient is. That patient is going to be brought into the hospital under observation or inpatient status. We get them admitted to the hospital, and then we do our further diagnostic treatment. Most important part of that is getting a history and a physical to go along with our diagnostic tests and radiological studies we do. We will make an assessment, and then we'll create a plan. And that plan might just be for the hospital setting, depending on the condition, or it might need to be carried out in the outpatient setting also. But our main job is in the hospital.
Okay. And so a patient goes to the emergency room, they see an emergency room doctor, and then there's a handoff to you, and you decide what treatment happens from there.
That is correct.
All right. What are some of the consistent trends that you're seeing in the type of patients you're treating, and sort of what do you think are some of the long-term risks that that our audiences, yet men probably aged from 18 to 34, what are some of the long-term healthcare risks that they should be aware of and should be preparing for?
Well, it's quite a few, but I'll try to narrow them down. One of the big problems that we're seeing right now is marijuana use. So we're seeing many patients come in
Really?
with nausea and vomiting, abdominal pain, severe dehydration, and this is from the marijuana.
This is overuse of it.
Well, not only that, it's not only the overuse. We don't know what's in
Yeah.
these drugs, and so they're creating GI distress. So when someone is vomiting violently, they can also tear part of the lining of the throat, and they might have a bleed. And again, we're not sure if it is that is causing it, so we'll have to do further investigative studies. But marijuana is a real big one. We're seeing a lot of what we call cannabis hyperemesis syndrome.
Wow.
So this is a known entity, and it's really causing a ding on the healthcare services.
And what are some of the other things?
I would say high blood pressure.
Yeah.
We're seeing it earlier because it has to do with our diet and lack thereof exercise. Modernized countries now, we're not doing as much exercise as we ought to. And so we're seeing people coming in, and not only coming in with new cases of high blood pressure, but sometimes in situations where their kidneys are already affected. And so that is really concerning for us all.
Wow. What are, given some of the things that you're seeing on a daily basis, what are the things that you would recommend people do just in preventative activities or things that they should be doing ongoing to make sure that they have better long-term health outcomes, and they're not having to be hospitalized and have to seek treatment?
I think one of the most important things is to access the healthcare system earlier. I do advocate and I do tell patients that they need to know that we do have health coverage for them in the event that they don't have for themselves. They can access facilities such as Grady clinics, Oakhurst clinics, Grady Hospital, get themselves into the system earlier. And that way we can prevent further destruction in some diseases if we catch them early. So again, early access to the healthcare system would probably be the most important thing.
And some of the places you mentioned are local to Atlanta. For those people that may be listening that are outside of the Atlanta region. So you said there's early access to or entering the healthcare system earlier. What are some of the entry points to the healthcare system before you get sick, before there's a major health issue? Where should you be going first? Who's like the first advocate that you should be talking to?
That would be a primary care doctor in the clinic setting. I see them as quarterbacks, knowing exactly what's going on with you, creating or building a relationship with you, communicating with you, and basically knowing you is going to be very, very important.
Now, for some people that may not even understand what a primary care doctor is, can you just sort of explain what that is and what is the extent of that relationship, and what kind of services a primary care doctor is going to be providing?
So a primary care doctor is a general practitioner. In the olden days, they saw patients from what we say from the womb to the tomb. They saw everything. Now medicine has become more sectionalized, but still we do have a general practitioner. They will see you for your history and physical. They also provide services for nutrition, diet, exercises. They provide immunization. So those are some of the services that they offer, mainly history and physical exam, diagnosing conditions that you might have or didn't know you have. That's the primary role. They also act as an advocate. They can be a go-between once you're admitted to the hospital. Some people like to have their primary care doctor involved, and again, that's the relationship that is created in the outpatient setting. And then their history and their information goes back to that primary care. When the patient is discharged, we do a summary of their admission, and that primary care doctor should be one of the people that information goes to, so they can see what happened in the hospital and what they need to pick up from.
So what I'm hearing, the primary care doctor is your doctor that you see that keeps your medical records, that knows everything that's going on with you, and they're similarly they're your primary point of contact, or at least your first point of contact when you're entering the healthcare system. Is that fair?
It should be,
It should
but
be.
many times it's not. Sometimes the hospitalist or the emergency room doctor becomes that primary, and this is what we're trying to prevent.
Now, can you explain why it's better for the patient and perhaps better for the hospital for the patient to see their primary care doctor first before they go to the emergency room if they have an issue? Or am I mischaracterizing that?
Well, it depends.
Okay.
It depends on if it's more of a chronic problem that is just bothering someone. If it's something that happens suddenly and they cannot access or they don't have communication with a primary care doctor, then certainly they make the best move. Sometimes it might be better for them to call ahead and see if it requires them getting an ambulance or not. But most people will call the ambulance, but we do have a fair amount of people that will access the system on their own by driving in or walking in.
Now, how do you know if you're having symptoms? How do you know if I need to just make an appointment to see my primary care doctor, or I need to go to the emergency room, or do I need to go to an urgent care? Is this something I need to go to a clinic for? How do you make the distinction? And oftentimes the patient has to make that distinction for themselves, or at least figure out how to make that distinction for themselves. So what would you recommend?
So pain is a vital sign.
Yeah.
So most times it's the pain that it becomes unbearable,
Yeah.
or something that is very strange or annoying, to the patient that will make them decide to come to the hospital. And sometimes it's good and sometimes it's bad, because if they're not having that fright or scare, sometimes they don't come, and it can get bad.
And this is a particular issue for men, because men, at least we like to pretend we have a higher tolerance for pain. We'll put up with stuff for a longer period of time. We in some earlier podcasts, we were just talking about some of the distrust with the medical system and some of the fear. Sometimes we just don't want to know what it is. Sometimes we feel, I can't pay for it. So what do you tell particularly men that just they're having symptoms and they're trying to make a decision whether or not they want to go to a doctor, and they're hesitant? What do you say to them?
I would say it's better to know than not to know.
Yeah.
As I said before, there are situations that can brew for a while and just continue to get worse. If we access or get information on that condition earlier, we might be able to cure it or take care of it. And so that's why I would tell them. I would say that if it requires them going to a primary care physician, many times they don't know how much it will cost. And so sometimes there are ways you can call those clinics and find out what is the base fee for me to be seen. It's best they do something like that. If not, they can go to some of the clinics that we do have in the community that will provide that care for them.
All right. I think you talked a little bit about this. When you, if it's an emergency, like if there's something to do with the heart, or you break a leg or something like that, that's the emergency room. If it's a chronic condition, then you need to see your primary care doctor. Is that correct, or should we be thinking about it differently?
For the most part, I think the patient has a sense of if it's getting worse or not. And we ask the patient to use that as a guide, because at the same time we don't want to overcrowd our emergency rooms with conditions like that. But if it's chest pain that is, crushing chest pain, they might be better for them to call and to get an ambulance, because if they need to have some care that starts from the outpatient setting or in their home, we can get that if there's an ambulance on board, versus them trying to drive in on their own. So in those situations, we always advise that you call the EMS system. They'll be a good guide.
They'll be able to advise you on what you need to do. Okay. In terms of a primary care doctor, what should a young man be looking for? Because everyone that we talked to said that just should be a thing that you just a part of your regimen. You should have a primary care doctor that's keeping your medical records and that can advocate for you. What are the type of things that you're looking for in a good primary care doctor? This is going to be a long-term relationship. This is going to be someone that's going to be with you for an extended period of time. So what are the kind of things that you're looking for, and what kind of relationship should you expect from your primary care doctor?
So I think the most important thing is trust.
Yeah.
Because with trust, it will dictate therapy. You know, if somebody's going to follow through with what their doctor says. Communication is always going to be the key. How do you communicate? Do you feel comfortable when you sit and you have to talk, especially when you're in your most vulnerable situation, having to take off your clothing and expose yourself to someone and have someone touch you? There has to be a level of trust and great communication where the doctor can listen to you. You want to have a doctor who can actually sit and watch you eye to eye. You know, that really creates a bond there. And so those are some of the things I would look for. And I want a doctor who also circles back and makes sure that I clearly understand what the issues are.
So it's someone that you feel comfortable being transparent and open with, and someone that is a clear enough communicator that they can communicate with you. Are there things that you need to be equipped to do when you go in to see your primary care doctor that can ensure, you know, he or she understands what's going on with you and they can give the right treatment? I know sometimes, you know, people aren't always the most transparent, and I've had instances where, you know, I didn't know what necessarily to say or what questions to ask. And so what kind of preparation do you need to do before you actually go see your doctor, so you can ensure that you get the best treatment?
Well, I would say knowing your family history is very important. And there are certain things that you can start out with. I think the real onus is on that physician and the skill set of that physician to extract information from you. You already know what's going on, but that physician has to be the one who's able to get that information out from you. So again, knowing your basic family history would be very, very important. Or knowing when things happen for the first time. When did you feel that chest pain? What was the surrounding circumstances? So those are certain things you would want to key in on. What happened? It's just like if you go to the mechanic and you say, hey, you know what? I notice every time I do this, this happens, right? And it only occurs when I do this. So those are some of the similarities between us and other professionals that I would like to bring to the patient.
Yeah, and so when you're listening to a patient and you're asking questions and you're doing the exam, what are the triggers? What are you looking for? What are you trying to get from that patient so that you can be better equipped to diagnose what's going on with them?
Well, I would say it starts from you when you go out to meet the patient, if the patient's in the waiting area, or once you present yourself in the room. In certain clinics, physicians will go out and greet their patients and bring them back to the room. And so you will, at that time, I would watch their gait. I would look and see how they walk. Or once I enter the room or they have to move or change clothing, I would look to see how they're getting up, how they're moving. That is part of my assessment. When I talk to a patient and ask them questions, how focused are they? Are they answering the questions correctly? So those are some of the things we look for. And then we'll do the physical exams. Of course, we listen to the heart. We want to hear how the heart is beating, if the rhythm is regular or not. If there is a beat, if there are what we call murmurs, if the doors are not closing or they're making noises when they close. So those are some of the things we look for. We listen to their lungs to hear if their breathing is equal on both sides, or if there's diminished breathing or what we call wheezes or loud lung sounds. So those are some of the things we look for. The belly, we want to hear the movement of the belly. You want to hear it making noises and talking to you. We want to look at their feet. We want to look at their nails, making sure they don't have buckling. Could be from smoking. Sometimes they have poor blood flow. We want to feel pulses. So those are general things that we look at. We can look at their eyes and make sure that they have equal gaze. Those are just some of the things.
Yeah, it's interesting. I wouldn't think that, you know, the doctor's looking at everything.
Yes.
It's how you walk and how you present yourself in order to figure out the diet. Because there may be some things that the patient can't even communicate that the doctor sees that the patient may not even be aware of. and once you get all this information, how do you then create a diagnosis and then make a treatment recommendation?
Well, it has to do with unless it's a first visit. But if it's a visit where they're coming in and they give you some information, this is why the history is so important and how we extract that information, because that, along with our physical exams, and then if we do radiological studies or lab work, then we can compile that data, that information, and say, this is what it is. We'll get an impression. We have something called a differential that we work with. And I'll give you an example. If you have chest pain, I would start from outside, the musculoskeletal. And there are other things that are going on in the chest. Is it the heart? Is it the lungs? Is it the bone? So those are the things we're going to look at. And then when I do my physical exam, when I press on the chest, you say, that hurts. Then I know it's mostly something external, and it's not necessarily the heart. So that's just a simple way of how we look at things. We put differentials together.
And how can a patient be better equipped to evaluate treatment recommendations? You know, if you're making if the doctor makes a recommendation, and so they have some choices, you know, you can do X or you can do Y or you can do Z. How can they better be equipped to make a decision?
Well, having an informed patient is always great.
Yeah.
So again, it depends on which part of that relationship is going on. Is this the first time? Is this things that have happened before? I like the way my doctors sit down, they talk to me, I can trust them. Now with Google, you know, a lot of patients
I was about to ask you. I know you said it's good for patients to be informed. Is that sometimes problematic? Because Dr. Google has put a lot of people in the grave, you know, just you're reading like, I got a headache and or something, you have a brain tumor or something like that.
So I would say it creates a good conversation, though. So even though they might be coming with, and that's what you want a patient sometimes to go read and come back and say, you know what? Well, this is what presents there. Yes, there's some validity to that, but it was not properly studied, or it's not the common practice, and this is how we do it, and this is why we do so. So that is already telling me a patient is already trying to get and be an advocate for themselves and trying to get further information on what's going on with them. And they just want to make sure that they be treated correctly. So again, this is where the trust and good communication is going to help.
So it's not a problem for you with patients just going to the internet and getting research and be able to ask questions.
No, I really know. I like it because it tells me that this person is interested in themselves. So I use it as a teaching point. And I think it's great. I really do. They're being advocates. They should be the number one advocate.
Yes. Yeah, that's come up in almost all of our conversations, just being informed, not only knowing your family history, doing the research about the particular symptoms you have so you can be better equipped when you go talk to your doctor. You had mentioned earlier just, you know, the marijuana use. There are a lot of people that may have some substance abuse issue, and they're coming to see you, and they're not 100% honest about what they're doing. And so, can you talk a little bit about how important it is for patients? Like you're not the police, you know, you're trying to help them medically, and sometimes people just don't want to be honest for a variety of reasons. Can you talk about how important that is, and what would you say to someone they're a little bit hesitant about being completely transparent?
I think it starts also with the physician or the practitioner, right? How they present themselves to the patient. And so the patient is looking for these cues. Should I be honest? And I do let the patients know. If I read their chart and I look in the hospital, I have the privilege sometimes of looking at their labs and seeing certain things. So then I can target my conversation towards that, looking and see what they presented to the emergency room with. And then I will actually go into those conversations, asking them, these are some of the things that I'm concerned about. And I let them know I'm a physician, not a cop. I'm not here to, you know, pass judgment or anything like that. I'm here to help you, and this is how I can help you. I'll deal with the immediate problem now. We can always discuss the things that led up to that right now. And that's how I kind of ease their mind on that. And then I let them know it's important. For example, with marijuana use, not going down some other dark alley in terms of trying to figure out what's going on. And so that helps me with them being honest.
Yeah. Just what are we were talking a little bit about primary care you know, when you go in to see your primary care doctor, how often should you be going in, and what are the things that you should be doing annually or quarterly? Is it blood work, or what should be what should you be monitoring with your primary care on an ongoing basis, and how often should you be doing it?
So that's a very important question. If I tell you the answer, you should have been seeing a doctor every year at least.
Every year.
From the beginning, the inception of life, with your parents taking you there. I think it desensitizes people from getting scared.
Yeah.
So if this was something regularly done and they see it as not as an intimidating place, I think they'll continue with that. So at least every year. There are markers and milestones in our health based on age. So again, those are the things you're going to be looking for when you hit a certain age. What are the recommendations for prostate exams? What are the recommendations for colonoscopy? But with you going every year, we can also pick up on things that are beginning to happen earlier. With us having a epidemic of diabetes and these conditions, we can pick up pre-diabetes, and we can actually prevent you from becoming diabetic once we lay out a plan for you. So those are some of the things that you want to do. That's why we want to go early, because, for example, diabetes you can have pre-diabetes for 10, 15 years before you go into diabetes. So again, if we catch this early, we can help do some behavior modification, and we can help you with diet and nutrition.
So you're going to see a primary care doctor once a year. They're doing blood work. I'm not sure what it's called, but it's a full workup.
Different panels, but yeah, we do. We look at your blood to see if you're anemic, make sure you don't have any infections. We look at your urine to make sure you don't have a urinary tract infection, make sure you're not spilling proteins in your urine. We look at your potassium. These are micronutrients that are very important for us. They keep your muscles in tune, they keep your heart beating. We look for vitamin D in African American communities. Our numbers run low. It's just because of our genetic makeup. So this has a lot of problems. Recently we are hearing it's playing a role in our immune system and even mood. So these are some of the reasons why we need to go and have those annual checkups, and then we can make recommendations based on those numbers.
Yeah, and so it's the urine, it's blood work, and physical. Someone's doing a physical exam. You should do that once a year, and that's going to give your primary care doctor the information that they need to be able to monitor your ongoing health. And just everyone, no matter how young you are, should see a doctor once a year.
I agree. Every year. I think some of the barriers are people not knowing this, people feeling healthy and feeling strong, and because they feel a certain way, they don't realize that things are breaking down slowly in the body.
I love what you said. A lot of us, doctor equals sick. So I only see a doctor or go to a hospital or see any kind of medical profession when I'm ill. And what you're suggesting is you need to see one before you get ill, just on a continued basis, just to monitor. Just like, I get my oil changed every 3,000 to 6,000 miles. You go get every 60,000 miles or so, you go get your car and engine checked up. We should be doing the same thing with our physical body every year.
Yes, I agree. I think we pay more attention to those things. We get annoyed when we see those lights showing up, telling us, hey, get your engine oil checked. And so we look at that much more carefully than we do our bodies. And there's an old saying that an ounce of prevention is better than a pound of cure, and I really do believe that. The earlier as I said before, the earlier we can recognize certain problems, we can actually avoid those things.
Yeah. Just a few more questions. One of the things that you see, you can get a better understanding of, I think you mentioned this earlier, you're seeing your primary care doctor, you're doing your annual checkup. They also are aware of your family history, and they can give you what kind of procedures you need to be doing at what age. And so, your colonoscopy, your prostate exam, ththose are typically 45, if I'm not mistaken.
Yes, African Americans, 45. Now the insurance companies are paying for those things. Before you had to word them in a certain way, And if it was not done correctly, the insurance companies wouldn't pay. And that's when a lot of times doctors had to be an advocate, a very strong advocate, to say, hey, you know what, my patient needs to be, to have this study done. But yes, 45 is a big age.
Yeah, and it is different if your family history has, from my understanding, say for colon cancer, for example, if you have a family history where people in your family have contracted colon cancer at a younger age, you can get a colonoscopy younger than 45. Is that correct?
Oh yes, and especially the types of, if you know the types of problem that they have, the cancer that they have, is even more important, because then you can start surveillance even as in your teens.
Really?
Yes, depending on, and there's some hereditary colon cancers that causes thousands of little polyps to grow in your colon, and so those are surveyed, and you might need to have your colon removed. So yes, it is very, very important that knowing your family history can make a big difference in your care.
Right, right. So we know a lot of young men, you talked about marijuana use again earlier. You know, a lot of young men use substances. They may, they drink, they may use, smoke marijuana, use some other substances. We're not here to pass judgment or say, you make decisions on how you're going to manage your life. But what would you say to them? What kind of recommendations would you have to someone who has decided they're going to, engage in using substances, and that's just the life decision that they're going to make? As a doctor, what would you say to them, and how should they be managing that decision?
It's funny that you've asked, because I've had quite a few patients, and this is how I answer that, how I deal with that. I come to them from a financial standpoint. Mm-hmm. So I had a patient recently, last week, and he came in, young man trying to do the best for his family, young family, has an 8-month-old son, has a girlfriend that he's planning to get married with, and they're living as a couple, and working hard, but smoking lots of weed. Mm-hmm. And he told me that he would smoke at least $200 of weed, $100 to $200 of weed a week. And so what I did, we sat down and we did a little math with that amount of money that he's spending. And so when I showed him, I think it came out to over $5,000 a year. And then we spoke about him putting that money, because he said, I want to do better for my son. I said, here's one option. You could cut back on your weed so you can give this child a chance to continue in a good pathway. So we looked at the economic impact on them. And then he actually, when I went back to see him, he had his girlfriend there, and he goes, this is the doctor I was telling you about. He was telling me how much money I'm losing. It's real, we gotta stop, I gotta stop, And the girlfriend agreed, and she was happy that I actually brought this to his attention. So I look at the economic impact. We also look at, again, the health concerns that you're going through. We're not sure what some of the chemicals are in the marijuana. Some of it has been spiked, actually, with other more addictive drugs. And so you might think you're just using marijuana, but it's got some other addictive drugs, and then you might have to go back to whoever's giving you this stuff to, say, hey, what's in this stuff? It's really making me feel great, and then they'll set you up with something else. So it's a gateway to a lot of other drugs. Marijuana is, but we can talk about alcohol the same way.
Yeah, and so what everyone tells you is moderation. But the problem with telling someone to use whatever substance moderately is that no one knows where that line is. Like, what's moderation? Like, what's balance? And how do you know when you're overbalanced in using a substance, at least in to a degree that's going to affect your health?
It's a very, very tough question. Let's look at alcohol. Yeah. Alcohol is a drug that causes a lot of problems, even not to the individual, but the families. Yeah. It's destroyed families, it's destroyed kids, the way how they perceive things. Alcohol is destroying you regardless of the recommendations of 2 drinks a day for male and 1 drink a day for women. You will get something called fatty liver, and you cannot live without your liver, because almost everything that comes into the body has to be detoxified by the liver. So you're putting an extra strain on that liver. And the thing about alcohol, how we know it's a poison, because it crosses what is called the blood-brain barrier. It doesn't even need to just go to the liver first and be broken down into its chemicals. It actually goes to the brain. That's why you feel nice. That's why you feel uninhibited.
Yeah.
So yes, it is doing damage to you, even though you're feeling like great. And I always tell the young men, alcohol is going to cause some body changes also.
Yeah.
Men who drink and drink extensively will end up having breast tissue, what we call gynecomastia. And it's overall, it's going to give them poor health.
Yeah. So overall, like if you're going to use it, you have to understand what the risks are and be able to sort of manage your decision based on, at least be informed in what the risks are before you decide at what level you're going to engage in using a substance.
And that is true, and a lot of times it's used when they're out partying and they feel good and they feel that, hey, you know what, I'm steady, I can drive. And you're not only putting yourself at risk, you're putting others at risk. You can, get on the highway on the wrong side and create a lot of destruction. So we tell people that even if they are going to do it, just be responsible. Have a designated driver. And now with having things like Uber and these things, and even with those, we have to be careful, because we have to be careful the cars that we're going into, who came to pick us up, how do we approach that kind of communication to know if this person is there for me or for someone else. So it requires a little more planning than they think.
Yeah. Sort of on the same lines, what advice do you give to guys who are sexually active and they're running a risk of getting some sort of STD? What should they know? How should they prepare and protect not only themselves but their partner?
It's a very, very good question. And I remember back in the days when things like HIV came out, we looked at people, how they looked cachectic and they looked a certain way, and we were stereotyping people as, oh, that person's got AIDS or HIV. You can't tell.
Yeah.
You cannot tell. So using proper prevention is important. And some of these conditions that you might find yourself in, or if you get some sexually transmitted diseases, they create scars in the uterine tube. And later on, you can end up having chronic prostate problems. So this is why we advise you, even if there's a cure for some of these diseases, sometimes they don't go away completely. So you have to make sure that you're not caught up. And especially in an area like Atlanta that is known for a lot of HIV, it's something you can't really predict. If you're having unprotected sex, you're having sex with everyone that unprotected person has been having sex with. And there are instances where people know that they have sexually transmitted diseases and they do not let you know.
Yeah.
They're angry. So you have to protect yourself.
Yeah, and also have some honest conversations with someone that you're going to be sexually active with, so you know what their status is, and they know what your status is. That's how you can keep both of you safe.
And I would say that even with those conversations, unless they're truly honest, because you meet the representative of that person, if you're meeting them for the first time, it would call for you really knowing that person, really wanting to make that leap. It's a leap of faith you're taking.
And this is also because some people, you may have a STD and not know. And so this goes back to what we were talking about earlier. You're seeing a primary care doctor, you're getting blood work every year. Do they look for STDs? Is that is something that's included? Can you request that it's included every year?
So yes, you can always ask for that. That is probably recommended by pediatricians at a certain age, and then once you move over into the adult world, there are certain studies you can ask for.
So one of the health issues that is pretty prevalent, particularly with African Americans, is sickle cell disease. Can you describe what the disease is and how it can be prevented?
That's a very, very important question, especially with sickle cell being a big bloodborne illness that we do have that people are born with. This is not a condition that somebody goes out there and they inherit like that or pick up. You're born with that.
Okay.
It's something you get from your parents. And so The the condition with sickle cell is that it creates a lot of pain and it affects multiple organs. And this is because of the shape of the cell. It loses its ability to be oval. And so it's more of a sickling, and that's why it's called. When it's viewed under the microscope, it looks like a sickle. And because of that, it can cause a lot of medical issues. It can sickle or clump anywhere in the body. And then with that clumping, you'll have poor circulation going to that organ, and then you can have destruction of that organ. For one, especially the spleen, patients can have their spleen rupture pretty early if they're involved in sports, or you can have your spleen basically dying off on you. So a lot of patients by the age of 10, they don't have a functioning spleen. You can have strokes. Many kids will have strokes in the younger ages, babies that have strokes because of sickle cell. And so it's a lifelong disease. There's no cure for sickle cell right now. But what you want to do, you want to talk to the young folks about if they're going to engage in any kind of activity, sexual activity. Let them know if they carry the trait or if they have the full disease. Because in that way, if their partner also has the trait or the disease, they can now have a child with that condition, and that is what you want to prevent.
How do you treat it?
Well, we try to do prevention, which is hydrating the patient. A lot of times if you're dehydrated, less volume in the body, more sickling, cold weather will affect it. So we try to, and good nutritional diet. So we add leafy green vegetables, but it's very hard to tell young people to eat leafy green vegetables or to hydrate themselves. So when they come into the hospital, again, we give them lots of fluids, we give them oxygenation, and we will give them pain medications. Now, herein lies the problem. Pain, sickle cell patients, for the most part, will always have pain. So it's not like they're pain-free, but what level of pain do they have? And then here comes the prejudiceness of the doctors or the healthcare workers, because this person is asking for pain meds, and we feel that they're drug-seeking. The results show that, the studies show that very, very small amount of folks that do have sickle cell disease actually die from drug overdose. And that is the problem. How do we relieve pain? How do we prevent this person from becoming addicted to this pain medication to the point where now they're going and seeking other forms of getting this medicine that we will send them home on?
I see.
Opioids is a problem, but how do we address true pain and prevent somebody from becoming addicted?
That's good. The last question is, if you're talking to a young man, he's maybe single or married, just kind of starting off with his life. He's generally healthy. He doesn't really see the need or feel the pressure to see a doctor or manage his health. He's worried about how much it costs and how much time it's going to take, and he plays ball every other weekend, so he feels physically fine. But what would you say to him as a doctor, and what kind of recommendations would you make to him to ensure that he has better long-term health outcomes, even though it may not feel like a priority right now?
And that's very, very difficult, because you have hormones raging, you have jobs, and you have some fancy things like cars going on, and the priority. I think prioritizing and understanding that at some point in time, even though you might be able to jump high and dunk, you're coming down on those knees, and there's shocks, and after a while they'll give out. I think using their car is one of the best things, example of how they should care for themselves. It is a very, very tough question, because it's something that we've actually created organizations to help women with that, and none has really been created for men. I think there are about 5 organizations for women, but none are for men at the federal level. So it's something that we really need to go aggressively after and try to give them these milestones and have them come in and know more of their history. I think starting with the family, knowing the family history would be important, knowing that some of the common causes of death, which is coronary artery disease and some of the things that can cause that. Diet and exercise is very important, nutrition. But again, not knowing these micro levels of things that are happening in your body are important. It is not just the physical structure. You could look at a house and say, oh, that house looks great, but you don't know the electrical or the wiring or the plumbing that's going on in that house. So it's important for them to understand that.
Yeah, it's good advice. Thank you, Dr. Barrow.
Thank you.
It's been a pleasure.
Pleasure. Thank you.
Right.
Pleasure's been mine. Thank you.
Thanks for listening to this edition of the King Culture Podcast. For more information on a plan for longevity, visit us online at kingculture.org and fill out your personal health inventory. Follow us on social media at King Culture Inc. And don't forget to like, comment, and subscribe.